A woman walks into the emergency room. She's having a dental emergency. The dentist gives her local anesthetic, a routine injection. Minutes later, her skin starts changing color. First pale, then gray, then blue, dark blue, like she's drowning. But she's breathing normally. Her heart is beating. She's conscious and alert. But her blood is the wrong color. And nobody knows why. This is the story of methemoglobinemia, a condition that turns human blood blue. Not slightly blue, not bluish, completely blue, like ink, like the ocean, like something from science fiction. But it's real. It happens. And when doctors see it for the first time, they panic. Because human blood should never be blue. The case that shocked the medical world happened in 2019. A 25-year-old woman in Rhode Island went to the dentist. She needed a simple procedure. The dentist used benzocaine, a common numbing agent, used thousands of times daily, completely safe, or so everyone thought. Within minutes, the woman felt weak, dizzy, nauseous. Her skin turned dark blue. The dentist called 911 immediately. Paramedics arrived expecting a cardiac arrest, expecting someone dying, expecting to perform CPR. But the woman was conscious. She was talking. She was breathing on her own. Her vitals were stable. Except for one thing. Her oxygen saturation was critically low. The monitor showed 67%. That should be impossible. People lose consciousness at 80%. At 67%, she should be dead, or at least unconscious. But she wasn't. The ambulance rushed her to the hospital. In the ER, doctors ran tests. They drew blood. When the needle entered her vein, something impossible happened. The blood that came out was blue. Not dark red, not purple. Blue, bright blue, like blue ink, like food coloring. The nurses gasped. The doctors froze. Because human blood is never blue. Never. It's red when oxygenated. Dark red when deoxygenated. But never blue. One doctor recognized what was happening. She had seen it once before. Years ago, in a textbook. The patient had methemoglobinemia, a condition where hemoglobin becomes methemoglobin. Regular hemoglobin carries oxygen. Methemoglobin cannot. It's useless. When enough hemoglobin converts to methemoglobin, the blood can't transport oxygen. The body starts suffocating from the inside, even while breathing perfectly. Methemoglobin is brown, dark brown, but when you see it through skin, it looks blue. The same way veins look blue through skin. They're not actually blue. It's an optical illusion, light refraction through tissue. But methemoglobin is so dark that it makes everything appear deeply blue. The skin, the lips, the fingernails, the entire body. The patient looks like a corpse, like someone who drowned, like something inhuman. The doctors immediately administered methylene blue. Yes, they treated blue blood with blue dye. It sounds wrong. It sounds backwards, but methylene blue is the antidote. It's a chemical that converts methemoglobin back to normal hemoglobin. Within minutes of injection, the patient's color started returning. The blue faded, pink returned. Her oxygen levels rose. Within an hour, she looked completely normal, like nothing had happened. But something had happened, something terrifying. How did benzocaine cause this? The drug is used millions of times yearly. Most people have no reaction, but some people have a genetic sensitivity, or take certain medications, or have specific conditions. In these people, benzocaine triggers a chemical cascade. It oxidizes hemoglobin, turns it into methemoglobin. The process happens fast, within minutes. The blood changes. The oxygen stops flowing. The body turns blue. But benzocaine isn't the only trigger. Many substances can cause methemoglobinemia. Certain antibiotics, local anesthetics, dapsone used for leprosy, nitrates in well water, some foods high in nitrites, even some topical creams. The triggers are everywhere. Most people never have problems, but for those who do, the result is always the same. Blue blood, blue skin, oxygen starvation. There's also congenital methemoglobinemia. People born with it. Their bodies constantly produce methemoglobin. They're blue from birth, permanently. Their blood is always partially converted, always somewhat unable to carry oxygen. These people live their entire lives with reduced oxygen capacity. They tire easily. They can't exercise hard. They live in a state of mild suffocation. Forever. The most famous case of congenital methemoglobinemia is the Blue Fugits, a family in Kentucky. They were literally blue. Their skin was deep blue. 4 generations. The family lived in isolation in the Appalachian Mountains. They intermarried. This concentrated the genetic mutation. By the 1960s, the family was famous. Doctors studied them. Journalists wrote about them. They were called the Blue People of Kentucky. The Fugits had a recessive genetic mutation. Both parents had to carry the gene. For children to be blue, the mutation affected an enzyme. The enzyme that converts methemoglobin back to hemoglobin. Without this enzyme, methemoglobin accumulated. It never cleared. The family members were permanently blue, but otherwise healthy. They lived normal lifespans. They worked. They had families. They just happened to be blue. One Fugate family member, Benjamin Stacy, was born in 1975. He came out blue, dark blue. The doctors panicked. They thought he was dying. They prepared emergency interventions, but his vital signs were normal. He was breathing. His heart was strong. He was just blue. Tests confirmed methemoglobinemia. As he grew older, his color faded slightly. He wasn't as isolated as his ancestors. He married outside the family. The gene became diluted, but he remained slightly blue his whole life. Methemoglobinemia can be fatal. If methemoglobin levels exceed 70%, death is likely. The body simply cannot get enough oxygen. Organs fail. The brain shuts down. The heart stops. But most cases are caught earlier because the blue color is obvious, impossible to miss. When someone turns blue, people notice. They call for help. They get to hospitals. Treatment begins quickly. The treatment is remarkably simple. Methylene blue injection. The chemical bonds with methemoglobin. It forces the molecule to release its iron. The hemoglobin reforms. Oxygen carrying capacity returns. The entire process takes minutes to hours. Most patients recover completely. No permanent damage. No lasting effects. Just a terrifying memory. An interesting medical story. But methylene blue doesn't work for everyone. People with G6PD deficiency cannot take it. The drug causes their red blood cells to rupture, to explode. The treatment would kill them. For these patients, doctors use alternative methods. Oxygen therapy, blood transfusions, hyperbaric chambers, vitamin C in high doses. These methods work slower, but they work. They save lives. Some cases of methemoglobinemia are intentional. Suicide attempts using nitrites. People ingest sodium nitrite. The chemical rapidly converts hemoglobin. The blood turns blue within minutes. Oxygen levels plummet. Death can occur quickly. Emergency rooms see these cases occasionally. They're difficult to treat. The amount of methemoglobin is often too high. The damage too severe. Many victims don't survive. There are also occupational cases. Workers exposed to industrial chemicals. Aniline dyes. Nitrobenzene. These substances absorb through skin. They enter the bloodstream. They cause methemoglobinemia gradually. Workers don't notice at first. They feel tired, weak, short of breath. By the time someone notices the blue skin, damage is significant. Industrial safety regulations exist to prevent this, but accidents still happen. Infants are particularly vulnerable to methemoglobinemia. Their hemoglobin converts more easily than adults. Well, water high in nitrates can trigger it. Contaminated water from agricultural runoff. Parents give babies formula mixed with this water. The infant turns blue, develops feeding problems, becomes lethargic. Without treatment, brain damage occurs. Or death. This is called blue baby syndrome. It still happens in rural areas, where well water isn't tested, where parents don't know the risk. The physiology behind methemoglobinemia is fascinating. Normal hemoglobin contains iron in the ferrous state, Fe2+. This form binds oxygen, carries it through blood, delivers it to tissues. But oxidation can convert iron to the ferric state, Fe3+. This form cannot bind oxygen. It's useless for oxygen transport. This is methemoglobin. The body has enzymes to convert it back. But if conversion happens too fast, the enzymes can't keep up. When someone has methemoglobinemia, their pulse oximeter gives false readings. The device shines light through skin, measures oxygen saturation. But methemoglobin absorbs light differently than hemoglobin. The oximeter gets confused. It shows low readings, often around 85%, regardless of actual oxygen levels. This is called the 85 saturation gap. Experienced doctors recognize this pattern. They know what it means. Blue blood is present. The only accurate test is arterial blood gas analysis, drawing blood directly from an artery, measuring its color, measuring its oxygen content, measuring methemoglobin percentage. This test is definitive. It confirms diagnosis. It guides treatment. Without this test, doctors are guessing, working with incomplete information, potentially making wrong decisions. After treatment, patients usually go home the same day or next day. There's no long-term monitoring needed, unless the cause was genetic. Genetic cases require ongoing management, avoiding triggers, taking supplements, sometimes regular methylene blue doses, living carefully, being aware, knowing the signs, knowing when to seek help. The woman from Rhode Island recovered completely. She went home that evening. The dentist changed anesthetic protocols, started using different numbing agents. The case was reported in medical journals. It became a teaching example, a reminder that rare conditions exist, that blood can be blue, that the impossible sometimes happens. Medical students now learn about methemoglobinemia in detail. They see photos of blue patients. They study the biochemistry. They memorize treatment protocols. Because even though it's rare, they might see it once in their careers, maybe twice. And when they do, they need to recognize it. They need to act fast. They need to remember that blue blood is real. Paramedics are trained to look for it, to recognize the signs. Blue skin with normal breathing, low oxygen readings with normal consciousness. These combinations suggest methemoglobinemia. Protocols now include asking about anesthetic use, about medications, about well water, about chemical exposures. Getting this history saves lives, speeds diagnosis, enables faster treatment. The blue blood phenomenon captures public imagination. It seems like science fiction, like mutation, like superhuman ability, but it's neither beneficial nor desirable. It's dangerous. It's potentially fatal. It's a malfunction, the body working against itself, chemistry going wrong, biology betraying its purpose. Some people online claim methemoglobinemia gives special abilities, enhanced night vision, better cold tolerance, increased endurance. These claims are false, completely false. Methemoglobinemia does nothing beneficial. It reduces oxygen capacity. It makes everything harder. It weakens the body. It has no advantages, only disadvantages, only risks, only dangers. The blue fugates taught medicine important lessons, that humans can adapt to chronic conditions, that reduced oxygen capacity isn't immediately fatal, that bodies compensate, develop workarounds, function despite handicaps. The fugates lived in mountains, at altitude, with reduced oxygen. In blue blood, they survived, they thrived. They proved human resilience, human adaptability, human stubbornness. Modern medicine can prevent most methemoglobinemia cases. Better drug screening, better chemical safety, better water testing, better awareness. But cases still occur because triggers are everywhere, because genetics vary, because accidents happen, because life is unpredictable. And when someone turns blue, doctors now know what to do. They recognize the signs. They administer methylene blue. They save lives. The patient who bled blue, the woman who turned blue in the dentist chair. She was lucky. She got treatment fast. She recovered completely. But her case reminds us that medicine still has mysteries, still has surprises, still has moments where doctors see something impossible, something that shouldn't exist, something that challenges everything they learned. Blue blood flowing from human veins. Blue skin covering living tissue. Blue proof that biology is stranger than we imagine, more variable than we expect, more capable of horror than we're comfortable admitting. Human blood should be red, but sometimes, in rare moments, in terrifying cases, it's blue. Completely, impossibly, horrifyingly blue.